Afternoon, everybody. Thank you for joining us. It's really great to have you all here and be able to share this great information. As Stacy said, my name is Catherine Martin, and I am the Executive Director of the California Immunization Coalition. And as Stacy also said, you are part of a larger audience, and so all attendees are in a listen-only mode until we get to the Q&A section, and then we'll open up the lines. If you need technical assistance, next, you can use the chat box. There's a little circle in the middle of your screen down at the bottom. Looks like a little chat box, a little blue circle with a quote image. And you can chat there with our operator or moderator, and we'll do our best to assist you. Or you can email our colleague Cecilia Lavu, cecilia.lavu@cdph.ca.gov, and we'll do our best. Again, today's webinar is also going to be recorded and posted on our website, immunizeca.org. Next. First, I'm going to give you a little bit of history on the Registry Committee at CIC and how we all work together, a little background, and then we'll move into the rest of our presentation. So for those of you who have not worked with CIC, the California Immunization Coalition, before, we're a statewide nonprofit. We are a lifespan coalition working on immunization issues and advocacy and education. So we do our work guided by a board of directors and an advisory council and a tremendous number of advocates who work on committees. We have advocacy, education, communication, emerging issues, and registry committees. And our registry committee has been part of our coalition almost since the beginning, since there has been a registry in various forms. A lot of work on promoting the registry and recruiting, and now we have taken on a new role. We've been a little quiet, let's say, for the last couple months, and now we are re-engaging with our existing registry committee members and our new members that we hope you will consider being part of. Next. So as you see here, we do a lot of work via committees. Our all-volunteer board chairs the committees. Linda Scott from Orange County and Amy Pine from Alameda County are our co-chairs for that effort. And this is our promo piece on getting involved in committees. And briefly here, it tells you that our past goals on the registry are to develop strategies to promote the use of the registry, build relationships with stakeholders, identify opportunities for advocacy, and keep everybody current on the registry through our communications. Next. And so what we're hoping to do on this call is bring you up to date on CARE 2, discuss the role of the new registry committee, and provide updates on our registry users group. At the end, Cecilia, another Cecilia, is going to do a presentation on the users group, and then we're going to review the next steps, including our proposed meeting schedule and platform for these meetings. Next. And so I'm going to give you one more reminder here that at the end, when we do have the question time, you have an opportunity. This image looks a little bit different maybe than your screen. It looks different than mine, but in any event, I think it's pretty clear to all of you that where the Q&A panel is, and this is where you can ask questions, and then I'll relate them verbally to the group, or we will have an opportunity also for live questions. So it gives you a number of opportunities to participate and get additional information at the end of the program. So now I would like to turn this program over to Edgar Endicott. He is the Chief of the Information and Education Section of the Immunization Branch at the California Department of Public Health. So, Edgar?
Thank you very much, Catherine. Good afternoon, and thank you for your interest in hearing more about our state immunization registry, also known as CARE. And as most of you know by now, we've recently upgraded to a new software called CARE 2. And for the longest time, our state has had nearly a dozen different registries acting independently, where immunization records weren't shared with one another, making it really challenging to get a complete immunization history and forecast for patients. Now, over the past year and a half, we've consolidated immunization records from 8 of the 10 regional registries across the state. And the San Diego Registry and San Joaquin Registries are anticipated to join CARE by the end of the year, so we're really close to officially being one registry. So I'm only going to talk for a few minutes, 20 minutes or so, and so that we have plenty of time for Q&A. I'll review some of the benefits of CARE, explain how to optimize the use of CARE, and the different ways sites participate in CARE. I'll also talk about some of our future plans, and then end with a few action items that you can consider. So from the state perspective, the main goal of having a state immunization registry is to protect communities from vaccine-preventable diseases. And to do that, health departments and providers need to be able to record, track, and assess immunization status of individuals and communities. CARE is a vital tool and system to help us do that. If we're able to assess immunization coverage of populations, then we're able to target public health interventions to address any gaps to prevent illness and outbreaks. So the use of CARE has really been it has been a long-standing requirement for all Medi-Cal managed care providers in California. So if you serve Medi-Cal patients, you are required to participate in CARE. And I don't know that a lot of providers are fully aware of this, but we're seeing more and more plans in California working to get their network providers to ensure that they meet this requirement. CARE is also required for meaningful use payments, and the ability to show that you can do bidirectional exchange is part of getting meaningful use stage 3 incentives. And then in 2016, the state California Board of Pharmacy released new regulations which mandate that pharmacists also use CARE. And then at some point, the VFC program will require that any provider receiving VFC vaccine enter their doses into CARE. So you can see that we're really heading in a direction where hopefully all providers who provide immunization services enter their doses into CARE. And that's really how many states, or several states, do that around the country. I know that our state's just a little bit behind at the moment. So, and all those requirements are a good thing, and that the more populated that CARE is, and the more that it's fully utilized, the more accurate our data is. And if we have the ability to assess vaccine coverage levels, then we can identify those gaps in coverage and then develop interventions to increase rates and prevent disease. So this is where you all can step in. You know, we really need your help in making CARE fully populated. And when it's fully populated, it's helpful for everyone: providers, plans, patients, schools, and public health. So what can joining the state registry do for your clinic? Well, it helps you provide better patient care by making sure immunization assessment is a regular part of your staff's workflow, allowing your staff to review doses given outside of your clinic, which is, you know, probably most of your patients' doses. This can include retail pharmacies, especially since some prenatal providers refer out to pharmacies. It can also help save your staff time, since they can just look into the registry rather than call or fax the patient's providers to get their records. So if you search for your pregnant patient in CARE and learn that she already received Tdap during her pregnancy from the retail pharmacy, then you know not to vaccinate that patient. You can also look into the CARE system and see what your patient's overall immunization coverage is like and try to improve your rates for Tdap and flu vaccinations. And then lastly, submitting your data to CARE can help provide meaningful use payments to your clinic. So like I mentioned before, a fully populated CARE can also raise rates, can really help by giving you more accurate data to assess rates and identify and reach members who need vaccination. This data can help you identify providers who may need technical assistance in improving their clinic's rates. And then during HEDIS season, a robust CARE database may eliminate the need to conduct chart reviews in provider offices, which we know can be really costly. The benefits to schools. It helps students meet immunization requirements as well as keep them healthy and in the classroom, avoiding exclusion. And then when CARE is fully utilized and populated, it can make the jobs of school nurses and school staff easier in checking and tracking immunization status of their students. And then for WIC and welfare offices, CARE can help their clients meet immunization requirements to receive essential services that they need. And then aside from meeting the requirement to participate in CARE for pharmacists, it can help them communicate any doses that you gave, with the patient's provider. It can help, you can look up which vaccines your patient needs, and then also ensure that your adult Medi-Cal patients get the vaccines that they need. So now I want to show you the range of how provider sites in California are utilizing CARE, and this table that I have up here describes three different ways that immunization data is submitted to the registry. And then we have the range there sort of juxtaposed against the evolution of the phone. At the very top, we have some providers who don't use CARE at all. They may or may not have an EHR. They may use paper records. Either way, their doses are not getting into care. And then we have basic use, where providers manually enter doses into the care to user interface or our website. They may have an EHR and are likely entering both into their EHR and the care interface. Data entry can be really time-consuming if your office vaccinates a high volume of patients. And then the next, which is the intermediate package here, and this is really how the majority of providers currently submit data into care. This is really around 85%, and this is through data exchange. They enter doses into their EHR, and then this data is automatically sent to our care database. So we also call this unidirectional. Data gets into care, but care data isn't provided back to the site's EHR. So the clinic staff must take that extra step of logging into the care user interface to see if that patient has doses in the registry. It's great that doses are going to care, but the downside is that staff have to take that extra step. So this brings me to the optimal use, and this is really what we're currently trying to drive providers to go to the most, and that's bidirectional exchange or the smartphone. And it's where clinician enters immunizations into their own EHR and then has the ability to query the care database through their EHR without going into the care interface at all. So it's still advisable that they go to the care interface every once in a while to make sure that those doses are being submitted successfully or for vaccine inventory management purposes, but it's not necessary to go there for every single shot given. So it saves lots of time within the clinic. So this is a table, if you were just looking at just VSC providers in California, here's a pie chart of how VSC providers are using care. And as you can see in the green, the majority are participating in care via data exchange. And in the blue, we have about 19% that are just using the basic user interface, and then a small silver and purple that are doing bidirectional or optimal use. So we really want that purple part to grow a little bit more. But if you look at the gray and the black, that leaves about 44% who are either don't have a care ID or don't use care. They're not submitting any doses to us. So over the next year or so, our branch is really focusing, our immunization branch is focusing on, the gray part, which is about 26% that do have a care ID, but for some reason stop submitting to us. We're calling these lapsed users. So for lapsed users, we could use your help in ensuring that they begin submitting again. What we do now is we notify lapsed users via email, and then we have a team of staff that also provides some follow-up. But it would be helpful if the organization could provide additional follow-up and support so that they can begin submitting again. Or if you have other ideas of how to reach these lapsed users, please let us know. So I just want to spend a couple minutes talking about how bidirectional exchange works and then how to sign up. It's super simple. Bidirectional exchange allows you to access care in your EHR. And the first step is opening the patient record within your own EHR and then clicking on the button to access the Care2 database. Next, you would find the matching patient within care by date of birth or other identifier. And then once you find that match, the missing doses retrieved from care would come up in a pop-up window and then give you a vaccine forecast of what's due based on both your EHR's records and care. And then lastly, you have the choice of importing all or some of those doses found in care into your EHR, and then it becomes part of your patient's permanent record. So here's a screenshot of how the pop-up looks like in Cerner's EHR. You can see on the left side, you can see the vaccine, the dates that they were given, and then you can click on the arrows to select which doses to import into your EHR, and then click on the Submit button right there on the bottom right-hand corner. So most of the times, providers will select all of the doses to import. So if you are interested in signing up for bidirectional exchange or want to get your network providers to start with bidirectional, here are the steps. Review the bidirectional exchange checklist, which is posted on our website. Talk with your EHR vendor to confirm that that they are bidirectional exchange ready. Most are compatible. And then let us know if you're interested in submitting a quick survey, by submitting a quick survey. And I have the link there below. And then at that point, our data exchange specialist would contact you or your designated IT person, and then to complete a test plan. And then after that test is successful, you'll be able to start using care within your own EHR. So more information can be found on that link that I have here at this slide. So here's our suggestions of what you can do to make sure more and more providers are maximizing their use of care. If you're not doing care at all, sign up for one of these 3 options that I mentioned earlier: basic, intermediate, or optimal. If you're currently doing basic use or manual entry only, talk to your EHR vendor to try to set up for data exchange, or better yet, bidirectional exchange. If you are participating in data exchange, make sure that you have at least one interface user who is accessing Care2 to look up and monitor data quality, and I'll talk a little bit more about that later. But also consider doing bidirectional exchange. It's going to save lots of time for you within the clinic. And then if you are doing bidirectional exchange, bravo. Just make sure that you are, checking that those doses are getting submitted successfully. So this is for health plans. I know we have a number of health plan participants on today's webinar. We do offer Care2 usage reports for health plans that are interested in learning more about their provider site's usage of the registry. The report allows health plans to see how and how often the provider enters their patient immunization data into Care2. It can also be a tool for health plans to identify which provider sites need more guidance to help maximize their use of care. So this is available now. And then in early 2019, we're planning on launching the health plan user role. This is distinct from all the other roles that we have for Care2. It gives health plans the ability to run their own HEDIS reports, as opposed to making the request through us and then us sending the report. So currently there's a bug in the health plan query functionality that needs to be fixed before we can make this available. Also, the query output needs to be updated to include CVX vaccine orders, which are now required by the HEDIS software. So because of those bugs that we need to address, the role won't be ready until sometime in 2019. So for now, we just want to get your input on the usefulness of this role. Since I believe we do have a number of health plans on today's webinar, just email Steve Nickel at the email address here on the slide, and let us know, do you want the ability to run your own HEDIS reports? Or are there other functionalities that you'd like for the health plan user role? So you're also welcome to send me a message if that's more convenient for you. You can send me a chat message on today's webinar. Edgar Endicott, just send that over to me, and that's more convenient. Or just email Steve. So now I want to share a little bit of what's coming down the pipeline. So this year and next year, we're going to continue efforts to get lapsed users to come back to care. We're going to promote bidirectional exchange. And then by the end of the year, we should be connected to the last 2 remaining regional registries, like I mentioned before. And then we just launched the Care Users Group, and that Care User Group is to help us get technical feedback on the system itself. So you're going to hear a little bit more about that in a couple minutes. We're also finalizing a data sharing agreement with DHCS, the Department of Healthcare Services, so that CARE will import Medi-Cal data from DHCS. So compared to claims and counter data DHCS provides to plans each month, data sharing at the state level will allow more historical records back farther than 12 months and will be in CARE, so creating a one-stop shop. And then in 2020 and beyond, we will work to connect VFC ordering with CARE, mandate that all VFC providers participate in CARE, link school and WIC systems to CARE so that school and WIC staff can look up immunization data within their own software, and then eventually broad recruitment, really go full bore in recruiting all providers, including private, who give vaccine to join the registry. So hopefully by then we'll have a big chunk of folks who are provider sites that are participating in bidirectional exchange. So I wanted to end with just a few action items to consider. You can really play a part in strengthening care by helping more and more providers maximize the use of care by trying to get them to do bidirectional exchange, or if they don't use care, to start participating in care. You can give us feedback, shoot us an email, call, or join an upcoming registry committee meeting to share your thoughts. For plans, again, we want to get your input on the health plan user role. And then in an effort to make sure that all those doses being entered are indeed going into the care system successfully, we strongly recommend that every care site designate at least one person to routinely monitor the quality of data that goes in and out of your clinic. So that you can really help here by ensuring that your providers have this in place. And then lastly, we're also thinking that your participation, and specifically in this committee, can also play a role in any advocacy efforts. Requirements, mandates, and support of these endeavors really need passionate and action-oriented people behind them. And it took a lot of advocacy, even by this committee, to get care where it is today. And will likely require more advocacy to get it to a place where it's fully utilized. So, hopefully this committee can be a space for that. And realistically, we're still 3 to 5 years away from being ready to try a full mandate for care for all California providers, but at future registry committee meetings, we'll discuss what needs to be in place before pursuing a broader mandate. So I'll end here with just a few links in case you want more information about some of the items I talked about, and I'll stop there and move on to Cecilia, who will talk about the user group, and then we should have some time for Q&A at the end. We do have some of our care team here as well to field some of your questions. Thank you.
All right, good afternoon, everyone, and thanks for joining us. So in terms of the care user group, we launched it back in June, on June 26th, with 55 members, all of who were actually self-nominated or nominated by someone at their organization. And just to give you a little bit of background on that, we did put out an email to all care users that have an email within the registry, just inviting people to nominate each other or to nominate themselves. We had about 200 responses, so not a little bit more than that, and out of those, we actually had some names that came up several times, which was a great sign. That let us know that they were active participants in the registry and that they could give us great feedback. And we also received feedback from the Care Help Desk, the CIC committee as well, the registry committee, and also from local care representatives who are our trainers that are stationed throughout California on the different nominees and who they would think would give us great feedback and would be great for the committee. So that was quite a bit of a process. It was all done through SurveyMonkey, the nominations, and we also requested some feedback from these nominees as to what were their top 5 priorities or top 5 things they would like to see changed within the registry. So I'll go into a little bit more about why we did that later on. But the objectives of this group is actually to identify ways to improve care too, hence why we asked them for the top 5 items they wanted to see in the registry or changes to the registry, prioritizing known Care 2 bugs, which have been reported by the different sites throughout the state, and also to help us review any software changes that we make before they actually go live to the users. So those are the 3 objectives of this group. Next slide, please. We have 2 co-chairs. So we have co-chair Michelle Barkis and myself, and then we have Amy Pine from CIC as the moderator. As I said previously, we did get feedback from CIC, and CIC was actually instrumental in putting it throughout this whole process, as we spent a couple months going through shaping what the committee would look like and how we would get this information out. So thanks to CIC. And just also, so you know, we do have users from various parts of the state. We tried to make it so that we would have representatives from different geographic areas in the state, as well as user levels, organization types, and manual entry / data exchange sites. Next slide, please. And we do meet every fourth Thursday of the month. A WebEx invitation has been sent out to all the members. We're meeting next Thursday, actually not next Thursday, but the fourth Thursday of August, on August 23rd. The commitment is 12 months. And just so you know what we do, we've actually had 2 meetings thus far. The first meeting was more introductory, letting everyone know what the objectives were, what the responsibilities were for being in the committee. But we also, during that first meeting, we did have a vote, and that was definitely proving to us what the purpose of this group is. And we actually had a meeting a couple weeks before that, and we've gotten a lot of feedback from users that they would like to see some changes from clinicians to shot givers or some other name that would be more representative of what the people giving vaccines out there are, what names we should have for them. So internally, we sat in a room trying to figure out what would be the best thing, and we said, why not bring it to the CARE user group? This would be a great start for them, so we did that. And so there was a vote that was put out, and at that time they decided for the user group to say, let's go back to shot giver, which is what we used to use with CARE 1. So those changes will be made. It will not be visible to users from the front end in terms of CARE 2, but you will see an account update that there will be changes from clinician to shot giver. And then in this last committee, from the feedback that we received on the top 5 changes they wanted in CARE or the top issues that they saw, we actually sent out a survey monkey before the meeting we had, and we asked them to actually rank it. So it was kind of like a practice run for them. It was a lot of questions, but just so that they would see what we would be doing moving forward. And we have bugs and enhancement lists internally, which we also will be working on over the next couple of months to see as users how this impacts their flow. You know, is it a positive change? Is it a negative change? How is it going to impact them at the clinic? So they have 3 different categories that they actually have to basically give a score to, and then we'll bring that back. Michelle and I will bring that back to the steering committee, which is internal, let them know what the feedback we received was, and then we'll end up scoring the other half of the categories that we have, which is it a CDC requirement, how many hours it requires from the DXC, the vendor, to actually put that change into place. So those sorts of things. So that's what we'll be moving forward with. And many of you at this point are probably wondering, what if we have a wish list of our own, and how can we report any issues to the registry if I'm not a part of this committee? So as I said, commitment is 12 months, so you can have a chance next year to actually participate, or you can also email us at carehelpdesk@cdph.ca.gov, and if you can give us a description of what you have seen in the registry, a bug that you saw. If you have seen those bugs, screenshots are really helpful, especially when it has error messages that you're getting, because that helps the vendor and the technical team identify where the issue is. And also, if you have enhancements, maybe you would like to see, some additional field added, that would be helpful for you. So you can just write that in the email and let us know, and we will bring it to the steering committee, see if it's something that's feasible, and then bring it to the user group as well for them to actually prioritize for future releases. I think that is it for me. So thanks to everyone.
Fantastic. Thank you very much, Cecilia Sandoval. I got the names of Cecilia straight now. So thank you so much, Edgar and Cecilia. Fantastic work, and we've got plenty of time for questions and answers. Did you want to add anything else, Edgar, before we get started?
No.
Right. Shall we open up those lines and see if anyone wants to give a verbal comment or question to start? And while you're doing that, I'll start with our first question online. How's that? While our operator is opening those lines. Let's see, one of our first questions is around how would a health plan find out which of their providers are, quote, lapsed? It would be great to get a report so when we conduct their provider visits, they can speak with them about it.
Yeah, this is Steve Nickel with CARE. Basically, there's a monthly user report, the CUR report that Edgar referred to, but we need the CARE IDs to actually run that report. So essentially the health plans would compile those CARE IDs for those contracted providers, submit them to me, and monthly I can produce a report for you. The report basically summarizes doses submitted from that site, either through data exchange or user interface, manual entry, as well as logins and the number of users. So the report gives you some sense for whether that site is actually engaged.
Terrific. Thank you. You know, on the same theme there on lapsed users, have you considered any other incentives for lapsed users, or are those not using CARE at all?
The branch hasn't.
Okay.
But this is Sarah Roy speaking. We do anticipate that some of the health plans, in order to comply with their contract with Department of Healthcare Services, will work with those lapsed providers so that they can, the health plans can meet the letter of their contract with DHCS, which requires that they ensure their network providers are participating in CARE. Edgar has put up on the slide the information about the CARE usage report, and there's also a link to our website, I think at the end of your slides, about the steps you can take to get us information we need to give you that report. Perfect.
And as a reminder, go ahead.
Yeah, I was just going to say there's a health plan user web page under the CARE users. I think you scroll down and there's a health plan user web page that actually has a lot of guidance on this process of the user reports, as well as there's a way to reverse engineer from your HEDIS reports who those providers are, and there's some discussion of that on that page as well.
So, Catherine, this link is not, Edgar, do you want to maybe mention?
Yes, and then we'll send a direct link to all the participants to the CARE user report instructions.
Okay.
That's not an active link? The CARE web.
That is an active link.
Well, why don't you just open it up and show it? So just go to declare.
I'll send it after.
Okay.
Yeah,
sure.
And the drop-down you gave was right. The drop-down you gave was right.
Yeah.
CARE users and then health
it's
plan.
CARE users and then it's help desk user or health plan users. Yes, yep. That's the link you need to go to.
Terrific. And as a reminder, these slides will be available online afterwards on the Immunize CA website. I think by tomorrow, no later than Friday, but tomorrow or Friday. It's only Tuesday, isn't it? This week, let's say. So we'll have it on our website this week, so you can refer back to it. And if there's any other resources that we get questions on during this call, we can place those there also. Do we have the phone lines open?
We do. Again, if you would like to ask a question, please press *1 on your phone. You'll be asked to record your name. Again, that's *1 on your phone. At this time, I show no questions on the phone lines.
Okay. You've done an amazing job then with the questions. So while we're waiting for questions, are there any other thoughts that you'd like to share, Edgar? And I
do have one question from the phone line.
Okay, go ahead, please.
Thank you. Rod 2 of HealthNet, you may ask your question.
Hi, everyone. This is Edgar. Thanks for the presentation. You mentioned about getting historical data from DHCS. Is that correct?
Yes, that's correct.
So that's wonderful news. So the health plans do not need to attempt to insert our historical data then.
I think we're going for a single feed from Medi-Cal. We haven't really talked about how historical that's going to be. I think that's still up for discussion. But potentially, yes, we would get some number of years of historical data
are working on a data sharing agreement with Department of Healthcare Services, and we're engaged in a pilot test now. So it doesn't exist yet, but that's where we're aiming to go.
Yeah, we hope.
That's wonderful. And regarding the Care ID, getting the monthly report to see the status of our providers, to see how active they are, is there any plan to allow the health plans to go online and punch in the Care ID to see the status immediately without having to wait for the monthly report?
Well,
maybe.
I think short of the HEDIS reports, I don't think we're inclined to let sort of the health plans have access to basically the whole sort of list of providers. We're sort of asking you guys to do a little bit of a lift here in terms of getting those IDs so we can pretty much laser focus the return usage report to your specific providers. So that's sort of what the plan is going forward. But we're happy to listen to suggestions from the health plan.
Okay, because that may be a useful feature to have if we're in the clinic already and we want to pull up the report immediately to interact with the provider or the clinic staff to see how active they are. Having that feature immediately accessible would be very helpful. And then you mentioned something about, sorry, I'm picking up all this question. You mentioned about reverse engineering from the HEDIS report to see how active the providers are. Can you explain that a little bit more?
Yeah, it's sort of simple because each patient is assigned a particular contracted provider. So simply by reviewing your patient list by provider, you could get a sense for whether they're using or not. So if that child ends up with an incomplete history or no history, I think the assumption can be that that provider is not using the registry.
But the most direct way, that health plans could find out the extent of their network's usage would be to survey your providers and ask them their Care IDs, submit those to Steve, and then each month we can give you the printout of exactly the level of usage of those providers. So we anticipate that health plans have lots of contacts with their provider network through email, through provider services, through visits. If you can get their Care IDs, we can run this for you. And that would also tell you from your initial survey, if you survey all your pediatric providers, for example, and half of them have no Care IDs, that tells you right there that those are missing.
Yeah, I think that's...
It would tell you the proportion that are participating if you survey them directly.
I think that's a good point. If you actually survey them and they can't come up with a Care ID, I think you can probably assume that they're not participating.
Then that could help you focus your outreach to them to say, hey, you know, you told us you don't have a Care ID. Here's the steps you can take to get one.
If they can't come up with one, then they probably don't have one.
Yeah. We're trying to partner with LA Care in Los Angeles to split up the list to gather the provider ID because we all have a huge overlap in the provider network in one time.
Yeah, LA Care, I think Anthem and LA Care, I think, are the only health plans so far that have submitted lists. So this is obviously this is a process which it takes a little effort, but it sounds like some of the health plans are starting to move in that direction. So these reports are available as long as you give us a list of those Care IDs.
All right, thank you.
But what a great idea, to coordinate with the other plan active in a particular county, because you don't want to have to both be serving the same providers to the extent your networks overlap. That's a great idea. I hadn't heard that before. Just like you coordinate for your facility site reviews and medical records reviews, that makes a ton of sense.
Yeah, we'll work towards it.
Yeah, because we don't know who's in your network. We can't look on our end, so you have to tell us that piece.
Great. Thank you, great to hear you, and hop in anytime with more questions as we go along here. So I have a question about the San Joaquin Registry, Merced County, for example. So you mentioned, of course, Edgar, that this year connecting the registries. I think the question is about, can providers there start using the Care Registry instead? Or can we expand on that a little bit more about how that process is going?
Yeah, we're trying to sort of avoid that. option for providers in a county because they really should be submitting data where to the registry that they live in. I think we only have another, six or 8 months, hopefully, before we're connected, so that should be a long-term concern. So I would encourage a provider just to sort of wait until we get hooked up, because then they'll see all the data for the state once we get hooked up.
Okay, super. And if we have any, for Oscar who asked that question, if you have any follow-up questions, go ahead and give us another call or chat there.
Connect with me and I can answer specific questions with Steve.
Exactly, perfect. Let's see, and as Stacy mentioned, it's *1, correct, if you want to ask a question verbally. Happy to hear from you. Another question, thank you, Cheryl, is around what if they can come up with a care ID, how would we know that they have lapsed? I'm not sure if I got that straight or not, but do you know what that's referring to?
Yeah, lapse equals no doses coming in. So these usage reports basically summarize for the previous 3 months how many doses have come in from that practice. So if there's no doses coming in, then clearly that site has lapsed.
So you'll know if you send us the care ID, and we'll tell you the status of that usage. So that's how you would know.
It's a spreadsheet with a lot of numbers on it. So if there's a 0 in that column in that row for that particular practice, that means we got no doses from them. So they're lapsed, basically.
Perfect. Okay, we'll switch back to anyone on the phone. While we're waiting for that, I have a question about if you want to take a few more minutes or a few more seconds here to talk about the bidirectional promotion. Edgar, that's something that intrigues me because when I'm talking about the registry in the community, people who know a little bit about it and have sort of followed along over the history, really excited. They're always excited to hear about that. But I don't know as much about it as I need to. Can you talk a little bit more about how we can, coalition folks or
we've come up with a fairly simple protocol. They obviously have to fill out the survey first. That's the first step to make sure that they're ready to go and that they've
so a provider fills out the survey.
Basically the site would fill out a survey and say they've talked to their vendor, they think they have all the qualifications. It's reviewed by our staff. Once it's reviewed and they look ready to go, we simply send them a test plan that we don't just distribute to everyone. We distribute only to the sites that we've sort of approved. And it's a self-directed test plan. What they would do is enter 10 false patients into their EHR system, and once they enter those false patients, they would essentially send a query for each one, get a return file. So that's what happens is a query is sent to care and a message is returned to their EHR system with that patient information. And we ask them to review that information for accuracy, but also make some clinical decisions about if you get a different address back from care, how are you going to respond to that? What is your clinical decision about whether you update with the care address or whether you leave it your address? So we force them through a couple of sort of mind games to a certain extent about how they're going to deal with this information that comes back. Plus, we ask them questions that they would only know if they actually returned the right patient. So that goes into a survey, and once they've completed that survey, essentially we push them to production and they can send messages to, this is all this testing is done in a test environment. But once they have completed the post-testing survey, basically we turn them over to production and they can send messages. We have probably about 500 sites in bidirectional at this point, and we get about 3 million bidirectional messages a month. So we're pretty expanded. Obviously, we have About 4,000 sites currently submitting unidirectional. That is one way. So we obviously only have a small fraction of the sites that are capable of bidirectional currently in production. So we have a long way to go with bidirectional. But it's a fairly simple process to get onboarded.
Right. That's very helpful. So first step is to
fill out the
survey checklist on the CARE side.
Yep. Checklist first, that sort of gives them info for the survey, then they fill out the survey, and our staff will get back to them if they qualify.
Perfect. Thank you. That's very helpful.
Catherine, if you want to, if anyone on the line is interested in promoting bidirectional exchange or CARE in general to lapsed users or people who haven't even started with CARE, we do have, well, if it's bidirectional, we have the web page that I linked there on the slide up there at the top, or at the bottom. But we also have a suite of promotional materials that'll be coming out probably in the next couple of weeks that kind of walks people through and describe just a little bit about the different packages that I mentioned. Remember the intermediate and optimal use of CARE, talking about those different options, what you need, and also a little bit how the registry can benefit your clinic or your pharmacy or your school, and then a number of materials also talking about bidirectional exchange, how it works, and how to sign up. So we'll have that posted probably in the next week or so.
Yeah, obviously this will, it's going to start ramping up. If we actually ever get to stage 3, it's going to start ramping up in the next several months as people try to engage. I haven't heard yet whether stage 3 will be a 3-month requirement or will be a full year requirement. But we expect much more interest in the next several months as people prepare for 2019. But the good thing is onboarding is fairly simple because it's really up to the practice themselves, the site themselves, to complete the testing process. It's not a heavy lift for our staff because we simply check the survey and answer any questions. So we can get a lot of sites up quickly. Plus, we're working with EHR hubs to sort of approve sites. I think Athena Health has been approved, so all their 400 sites can move to bidirectional as soon as Athena Health decides to do it. Other partners, the same sort of situation. So we can get these numbers up fairly quickly. So that's why you need to check with your vendor to see if the vendor's already been approved.
Okay, wonderful. Thank you so much.
We do have I was going to say, we do have one on the phone line. Michelle Scott, you may ask your question. Michelle, your line is open. Please check your mute button.
Hi, my question was answered already. Thank you.
Thank you. Thanks for being on the call, Michelle. Another question we have on the Q&A here is about how can health plans gain read-only access to search the immunization history for specific members? Is that a possibility?
Yeah, that's pretty much, the help desk probably could be doing this, but I've been doing it so far because there hasn't been a ton of people interested in that kind of access. But if you're a health plan, simply send me an email. You have to sign the health plan agreement before I give you access, but there's a health plan agreement on the health plan page, the user page. Fill that out and send me the names of people that you want to have read-only access, and I'll create the account.
Excellent. Any more callers?
Danelle Wallace, you may ask your question.
Hi, it's more of a comment. I think that the meaningful use for eligible providers is proposed to be 90 days for stage 3.
That's probably why we're not. we don't have a lot of people, rushing to our door because they have sort of backed away from that full year commitment. But it's really a valuable. I think it's a valuable activity to be to not have to access CARE, essentially to be able to send messages to CARE and retrieve information from CARE, because it is a little confusing if you have to keep your EHR open as well as CARE to look up patients. So it's a really, I think, valuable way to get value from care too. So we encourage people to do bidirectional. Yeah.
Definitely.
Hi, Catherine. This is Edgar. I'm wondering, since we have some health plans on the line, and I talked about this on an earlier slide about the health plan user role, and the main functionality for that will be so that you can actually run your own HEDIS reports as opposed to making that request through our department and us sending you the report. So I guess I'd love to get some
disclosure will be required.
Disclosure, yeah, will be required for this.
So I think that's a limitation that many of them are feeling. So. Yeah.
But before we forge ahead with this user role, I just want to get some sort of initial reactions or input on whether you think that this would be useful.
And maybe just take a minute to say what is a HEDIS report in case not everybody knows.
Well, yeah, a HEDIS report is simply the health plans provide us with a list of patients in a particular format. It's essentially in this new option, it would have to be formatted such in a certain way, and basically would be dropped in the front end of the registry rather than handed off to one of our report staff. Mark Foster is the person who receives this now, so you'd be able to do this yourself. But a HEDIS report is simply a list of patients is sent to us. We do a match against the registry. It's an exact name, birth date match, and we return any vaccines associated with a matched patient. That's essentially the HEDIS report that we return.
So the health plan uses that data then to develop their, to look at the HEDIS performance measure, to do follow-up to get kids caught up, and to have be proactive and try and improve performance on these measures. So we typically get them for 2-year-olds and preteens, because those are the 2 measures that health plans are required to report to DHCS.
So the significant difference would be that instead of sort of dropping this off in a box and having this done for you, you could actually come into the front end of the software and run them yourself at any. There would be some limits, because a lot of these are fairly large reports. So we would sort of request sometimes that they be run off hours potentially. But the other part of it is that you would have to disclose your health plan patients, because when we run these patient lists in through the interface, it actually adds the patients to the registry if they're not already in the registry. And for that reason, they would have to be disclosed.
So the disclosure is a state law as part of our authorizing statute, and health plans typically do this disclosure by just in their new member packet or their annual newsletter tell their members that unless you opt out, you will be your provider will be unless the patient individually opts out, your provider will be engaging with care. So it's a very easy step to do this disclosure and meet the legal requirements. And we have a page about disclosure on our website.
Yeah, it could just be a process going forward. If you're not disclosing now, you would just put something in the packet to disclose facts of patients can be added to care by the health plan.
Excellent. So in the couple minutes we have remaining, I wanted to follow up with anyone on the line. Edgar wanted to get some feedback. Yes. We all wanted to get some feedback.
So the question from the health plans is, do you really need this functionality, or can you live with the old functionality? I think that's the main question.
Do you want to be empowered to run your own reports? Do you want us to keep doing it?
So if you don't want to give feedback now, that's fine, but we'd appreciate feedback, because if we're going to make these changes, we have to probably start prioritizing them now. If you don't care about it, then we don't have to worry about this, because we can, the back-end queries the Marks run, and we can easily export CVX codes and do that stuff. But if we have to change the interface, that's going to have to compete with other bugs that we have currently in the system. So any feedback from you about making that kind of decision is really helpful.
I've got one participant that says we want to run our own reports and be able to add shots. And so what I'm thinking is, since we're close to the end of the hour here, we do have a transcript of all these questions, so the ones that we weren't able to get to, we can answer offline. And all along the way, as everyone on the call has heard, tons of people making their emails available to you for all these specific questions, and I know they will, if you get the wrong person, they will direct you to the right person. So really appreciate all this information. Every bit counts and helps. I wanted to real quick talk about our next steps. While the Registry Committee has been meeting monthly for the past 8 or 10 years, we're feeling the need right now that quarterly might do the trick. And if we use the WebEx platform, we might be a little bit more effective and efficient too. So we'll send out some follow-up information. Does that sound good, Edgar, Dr. Royce, Steve? And poll the group to find out if that continues to work for the group and our chairs. Does that sound good?
Yes, sounds good. Sounds good. Thank you.
Any last thoughts as we conclude?
No, we'll send out some more information on, I think a lot of people are interested in the health plan user information, so we'll send that out shortly after this meeting. And then again, this is recorded, so we'll send this out as well.
Exactly. So we've reached the end of our webinar, and we're going to stay right on time. And I want to thank Edgar and Cecilia, Dr. Royce, and Steve Nickel, everyone for their presentations today. And especially thanks to everyone on this call for participating, and Stacy for being our great producer here to make sure everybody got on the call. So with that, I will conclude and look forward to hearing you on our next call. And make sure you get a hold of us if you have any follow-up questions. Thank you very much.